I would like to invite Dr. Julius Xavier Scott to chair the next session. Dr. Julius Scott is a professor of hemato-oncology, Sri Ramachandra Medical College, Porur. I would like to call upon Dr. Siddharth S., final year MD Pediatrics PG from ICH to present the case.
I'll start with the good news for you all, okay, so that you will wake up. I'll follow that with the bad news. The good news is, as an examiner, I have not failed any candidate so far. No, seriously, so far. But the bad news is I'm not going as an examiner nowadays. I have restricted myself for a particular kilometers in and around Chennai, okay, because of my commitment to the other works. So that is the news for today. So mostly for exam some points and majority for the points in clinical practice we will teach here. Start.
Good morning, one and all present here. A 3-year-old female child, firstborn of non-consanguineous marriage, brought by mother from Miluppuram, whose reliability is good, with the complaints of fever for 21 days, with abdominal distension for 21 days, and increase in pallor noted by mother for 15 days, and swelling in both sides of neck for 15 days, with pain in the leg for 15 days. History of presenting illness: fever for 21 days, which is a high grade intermittent fever not associated with rigors and relieved with medications. There is a history of abdominal distension for 21 days, which is predominantly upper abdominal distension, which is gradually progressing and not associated with any abdominal pain. There is a history of swelling noted by the mother in both sides of neck for 15 days, which is insidious in onset, gradually progressive, not associated with a difficulty in swallowing or a pain. Initially started on the right side of the neck, and later it involves the left side, and no discharge from the swelling. A history of pain in the leg for 15 days. With the child, mother noticed the child is not able to walk or finding it difficult to walk, and there is an night awakening associated with the pain in the leg. There is an increase in pallor noted by the mother for 15 days, which is gradually progressive and associated with the easy fatigability. There is a history of past history. For the above complaints, the child was taken to a nearby hospital where the child was treated with IV medications, and for further care the child was referred to the higher center, Institute of Child Health, for further care. There is no history of long term any drug intake or no blood transfusions. There is no any hematological disorders in the family. Antenatal history: mother was registered and
significant alone you highlight, otherwise
there is no history of any chronic drug intake or radiation exposure in the mother during antenatal period. Natal history: full term normal vaginal delivery, birth weight was 2.75 kg, cried immediately after birth. There is no history of any NICU admissions. Development history: attained age appropriate milestones. Contact history: no history of contact with tuberculosis. And diet history: there is a deficit of 405 calories, and protein is 4.5 calories. Grams. Immunization history: immunized up to the age as per National Immunization Guidelines Program. No special vaccines has been advised for the child. Family history: family of 2, and it's a non-consanguineous marriage, one child, no other significant family history. Socioeconomic history: the child is living in a semi-pakka house, 2 rooms with separate kitchen, toilet facilities available, uses mineral water for drinking and corporation water for other things. Father is working as a cab driver and earns around 15,000 per month, and according to modified socio-economic scale, belongs to the middle class. And now
summarizing the history, I just want everybody to understand only one line from the total history. I have not corrected or edited anything, but I just read once. So it's a true case, and you know the diagnosis because the topic is already being given. So my point is, among all the words what he narrated from the name up to this, which one points to the diagnosis of malignancy here? Okay, correct. It's the pain. Pain, excruciating nature, disturbing the quality of life, awakening the night. Okay, this is learnt from 80s. There is no further technology improvement to modify this statement. It is an experience of a child and the mother. You understand? The fever can be multiple causes, swelling in the neck can be multiple causes, anemia can be multiple causes. I am not saying pain is only malignancy, but among all these, the diagnosis of a referral letter from that government hospital to this government hospital should be acute lymphoblastic leukemia. If you don't write that, you are failing in that exam, not this exam. I am not going to check whether that government hospital referred as ALL or not. I am not going to discuss here how to tell in the exam what all the common causes. Malignancy should be the least possible. All the discussions is not going to be appropriate here. But in clinical practice, if this child is not diagnosed as ALL, you are making an impact on the child's life. Okay, the delay in the diagnosis cannot be appreciated in this child if the symptom complex is true. You all understand? But now next each point what we should have done means I will highlight. So we are not going to tell any differential diagnosis of lymphadenopathy or pallor, all that will come in different classes. Is that point very clear? In a child particularly, an adolescent can have a psychological problem. What is the age of the child?
3 years.
In 3 years, if somebody is pain disturbing the sleep, it cannot be JAA. This has been confirmed with my friend rheumatologist. You understand? So is that clear? Okay. Apart from that, I don't think there is anything particular relevant in the antenatal, natal or postnatal. Nothing is there.
General examination, child appears alert, afebrile, cooperative.
You highlight only the positive findings.
The severe pallor is noted and generalized lymphadenopathy is noted. There is a bilateral cervical lymphadenopathy, anterior and posterior cervical nodes.
For you is it a significant lymphadenopathy or not? Because invariably every child will have a lymphadenitis. Okay, in your clinical practice, is this significant?
The largest machine 2 centimeters.
So according to the size, it is more than 2 centimeter, and if there is a site, particularly suboccipital or preauricular, epitrochlear, some sites are significant, and associated findings like matching or any sinus formation is significant. So lymphadenopathy is significant, yes. Then
there is a bilateral axillary lymph node present 1.5 cross 1.5 centimeter in central group, which is firm and fixed. Bilateral inguinal lymph nodes horizontal group is enlarged on both sides, measuring 2 cross 1 centimeter, hard, fixed, non-tender, and no warmth. No icterus, no cyanosis.
All these words in the lymphadenopathy, which one points towards malignancy? Fixed. Okay, fixed. Even apart from the size, the fixed. So that is also equivalent to that pain. So 2 points we have taken. Next.
It's a picture of the child. And head to foot examination, skull appears.
There is nothing significant now.
Anthropometry and vitals. Anthropometry weight.
Also not very significant.
Systemic examination.
Just tell the positive finding and the palpation.
Palpation, superficial palpation, warm, non-tender, mass palpable in the right and left hypochondrium. On deep palpation, liver is palpable 7 cm from the costal margin, which is firm, non-tender, well-defined margin, smooth surface and sharp borders with round edges, moves with the respiration. And spleen is palpable 9 cm along the long axis, firm, non-tender, moves with respiration, splenic notch felt in the anterior borders. Percussion, liver span is around 12 cm, no free fluid. Auscultation, bowels on heard, no audible bruise. This is a picture. And other system examination normal.
What is your final summary?
The positive findings are summary. There's a child is having a fever and with increase in pallor which requires a blood transfusion, and there's a bone pain is there, a lymphadenopathy and massive hepatomegaly and splenomegaly. So my diagnosis is acute.
From exam point of view, you divide your differential diagnosis into infections, autoimmune and malignancy. For our discussion, we will just focus on malignancy now. Okay. If you are already suspected malignancy in a child with systemic constitutional symptoms of fever, lymphadenopathy, hepatosplenomegaly, that is lymphoproliferation, with the bone pain, your diagnosis will become acute leukemia. If I exaggerated or think of some other malignancy can present like this means, one more malignancy, neuroblastoma with multiple bone lesions with stage 4 disease still can have lymphadenopathy, hepatosplenomegaly. Okay, nothing else. Bone tumors can be specific pain in some areas. So I can only say acute lymphoblastic leukemia as a differential diagnosis. Now, few important points in head-to-toe examination. If it is acute myeloid leukemia, in an epidemic of dengue, a CMC trained pediatrician in Tirunelveli with multiple dengue fever with pancytopenia, with the child who was diagnosed with dengue with pancytopenia, because of one finding he contacted me and referred us AML. You understand? In a ward full of dengue. What is that? Gum hypertrophy. So there are some specific stigmata of leukemias. In AML you can have gum hypertrophy or chloroma or something which is projecting, proptosis. All these are malignancy findings. In malignancy, another important point in head-to-toe examination is some malignancies can be associated with syndromes. So particularly Down syndrome, that features is there means with hepatosplenomegaly with high counts. For a newborn means what is your diagnosis? Transient but myeloproliferative disorder. But older child less than 3 years is AML is common, more than 3 years is ALL is common. So both. So that's all we need. Next.
Investigations, complete blood count shows hemoglobin is 4.4, total count is 2600, differential count is only lymphocytes is in 86%, platelet is 1.24 lakhs, and MCV is 67.1, MCHC is 27.4, RDW is 24.9, and renal and liver function test revealed.
In this the striking abnormality is the third statement. First statement is pain, second is a fixed immobile lymph node, third is not anemia, predominant lymphocytosis. Many people will miss this, but the strikingly what is not there is a MCV not being high. The old test many gold tests are there. You understand? More than flow cytometry, I can make a diagnosis of leukemia by a simple complete blood count. You understand? I will show you some examples after his presentation. So high MCV, predominant lymphocytes, low normal white cell, low normal platelets is the classical ALL when there is associated with bone pain. Okay, so don't forget about high MCV. For exam purpose, high MCV means think of megaloblastic anemia first, hypothyroidism, you understand, liver disorder, all that. But high MCV associated with pancytopenia, predominant lymphocytes, it's leukemia. So this is very classical. What is strikingly normal is, next I will go into the uric acid only. If the uric acid is high, then you have to look at creatinine. If the creatinine is high, then you look at phosphate. Phosphate is high, you look at calcium, the calcium will be low, then finally potassium. These are the 5 components of tumor lysis syndrome: hyperuric acid, high creatinine, we can put third as hyperkalemia, then hyperphosphatemia, hypocalcemia. That is the only thing. So this is where the child will die. You understand? So if you suspect infection, then you give antibiotic for 72 hours. Then you suspect autoimmune, because the examiners will feel bad if you suspect malignancy on the first differential diagnosis. But the mother will not leave you. You understand? Examiners will leave you, but the best examiner is mother, father, and an uncle who is a lawyer also. You understand? And he would not have studied law, but he will have only a certificate. So that is even more dangerous. So I would want everybody to understand what is the first investigation. Even if you miss out CBC is okay. People will concentrate more on platelet transfusion, anemia correction. They will get worried if the anemia is corrected, blast will be missed, nothing will be missed. Hemolytic anemia, coagulation disorder, megaloblastic anemia, all that can be confused by your transfusion, but not ALL. So you should refer to a higher center after transfusion, after platelet transfusion, Paxil transfusion, check uric acid, start allopurinol hydration for a strongly suspected leukemia. If a child is transferred from your unit from down south on Saturday and reaches here on Monday, on the way had a cardiac arrest, found to have a potassium of 11.5 and uric acid of 13.2, then the question will, you could have diagnosed this earlier or not? Obviously I would say yes only, but I won't tell outside to you. You understand? So be very careful about this page. Next.
Peripheral smear examination reveals RBC count is reduced, normocytic, normochromic RBC.
So there is blast in the peripheral smear itself. But will you do bone marrow or you do peripheral blood flow cytometry? That is the question. Will you do bone marrow? Already peripheral blast is there. More than 20,000 white cell count, more than 20% blast only, you can do a peripheral smear. So you have to do a bone marrow. Next. Okay. This is the most important investigation before transfer again, next to uric acid and potassium. Why? If a child with ALL with a mediastinal adenopathy missed and transferred without a precaution of telling the tertiary care center, or sedated on the way for a CT scan or any investigation, or sedated for a bone marrow without making the X-ray seen by the senior doctor, again the child can die. So mediastinal widening can never be missed, and any procedure for sedation, you have to do a chest X-ray to rule out mediastinal adenopathy for a child with suspected leukemia or any malignancy, even for tuberculosis, if there is a mediastinal widening. And death one you can never understand unless you see a child die. You understand? Went well from the toilet, playing, went to theatre, not come out of theatre. This has happened in many times. I will show you one more example. Next.
Bone marrow examination reveals marrow elements markedly replaced by monomorphic population of blast cells, which is more than 50%, and lymphocytes and few NRB seen. Erythroid and myeloid megakaryocyte decreased in count and morphology and distribution. Impression is acutely.
So it's very clear. So from the symptom complex, all the necessary investigations and the diagnosis is made. What next?
Next is flow cytometry results.
So flow cytometry, first I will tell you CD19, CD10 is positive. CD22, these three things is enough for making a B cell ALL. If it is T cell, it is 3, 5 and 7. I don't think for an MD pediatric exam you can go that much deep, but at least flow cytometry is the final diagnosis. B cell leukemia is the diagnosis. Okay. CD10 positivity has a good prognosis. Infant ALL, CD10 will be negative and they will have MLL rearrangement. So all the three are bad. Infants, CD10 negativity and MLL rearrangement. Next.
It's a karyotyping fish.
This is the next most important test. I was very impressed by that ICH patient has got all the investigation which could have been done in Apollo or any private hospital. So that is something which is very remarkable good thing. So this is fish translocation. There are 3 fish translocations are there. We can do much more, but at least this 3 is needed because BCR ABL, if it is positive, you have to start imatinib. Otherwise, the child will not improve with a conventional treatment. Then TEL AML, that is the last one. That is the most common genetic abnormality in ALL, which has the best prognosis. So the treatment will be de-escalated. So every treatment is modified according to the translocation. Next slide.
It's other echo showed normal, structurally normal heart, and CSF analysis shows no cells or blast in the cerebrospinal fluid.
This is like breaking news, big news. This line, I will read that line, and then you have to tell me from where is it taken. Okay. The initial lumbar puncture for any ALL child should be performed by an experienced procedurologist. I have never heard that word. You are used to that word? Procedure pandravan, procedurologist. Because a traumatic lumbar puncture is associated with increased risk of CNS relapse. Obviously, I didn't write this. I don't have this much good English. Very good. Nelson textbook of pediatrics. Yesterday only I studied again, many years later. This is 19th edition. I studied 14th edition. Okay. But 14th edition, this was not there. This I learnt only in Australia in 2005. Because every time the lumbar puncture in CMC Vellore, I am standing here because of CMC Vellore only. Okay. But in CMC Vellore, every lumbar puncture is done only by the junior most person, like me. So if you are practicing that today, you stop that. I don't want to check. But in my institution, only consultants will perform lumbar puncture. If they don't perform, they will not continue there. You understand? That is a practice in Australia because you are increasing the chance for relapse knowingly. So if a CRRA asks for a permission, he will do it for the third year or second year maintenance LP under sedation after getting permission from parents or without. If any parents are here? Okay. Or inside the theater we will say that we are doing, but we will supervise because there is no implication. So I am very glad that Nelson textbook of pediatrics says in the pediatric chapter about acute lymphoma. There is nothing important for passing the exam. You understand? Next. Okay, this is what this is also taken from Nelson. So I don't want anybody to criticize that I have been doing more of oncology from any oncology textbook. This is from Nelson. So in Nelson, if they have given that trisomy 4, 10, 17 are favorable prognosis, you have to know. But most important is TEL AML, that is 1221, and the worst is hypodiploidy 922 and 411. But 922 has a different treatment, that is imatinib mesylate. That's all you should know here. So hypodiploidy is worst, hyperdiploidy is best, TEL AML is best. Okay, so if there is an advanced pediatrics theory paper say cytogenetics in ALL, you can say this few points. Instead of saying cytogenetics is very important in ALL, cytogenetics is very useful for ALL, adallam nothing will carry mark. You understand? Next. Okay, this is the prognostic marker by which this child will be diagnosed whether this child is standard risk or not. Let us go through each. So this child is what age?
Sir, 3 years, sir.
So favorable or unfavorable?
Favorable prognosis.
Okay. Total count is how much?
Less than 50,000.
So, so
less than 50,000, sir.
So pancytopenia is good prognosis. You understand? So that is favorable. This child is Scala positive or not? That is CD10 positive or not?
No, sir.
No, CD10. I showed you in the flow cytometry. That is positive. So yes, CD10 is 96.9%. That is positive. We don't know the trisomy of cytogenetics, but adverse cytogenetics are absent. 922 is fish, is negative. Karyotyping has not come yet. And the child has got early prednisolone response or not, we are not going to calculate that, but the child is already got only 2000 counts. The blast is only 5%. The blast count should be less than 1000 at day 8. Now the blast count is already only 100. You understand? So the child belongs to favorable risk group. That's all. Next.
Treatment, there are two treatments, physic and supportive treatment. This is a supportive treatment.
This I will read this. This is again from Nelson only. At least somebody who has never read Nelson so far and you are depressed now, you can go through that now. Okay. Close attention to the medical supportive treatment needs of the patient is essential in successfully administering aggressive chemotherapeutic programs. Patients with high white cell count are initially prone to tumor lysis. You understand? Kidney failure associated with very high levels of serum uric acid can be prevented or treated with allopurinol, or urate oxidase is raspbericase. There is one drug. Again, recent advances, like if I am asked to ask some question, I will ask that. It is not recent advance, 20 years before, but still it is recent advance. Okay. Chemotherapy often produces severe myelosuppression, so again with high index of suspicion, febrile neutropenia, sepsis and septron for PCP. So first paragraph we are talking about the initial complication of either due to the leukemia tumor lysis or due to treatment neutropenia. That's all. Two things is enough. The successful therapy of ALL is a direct result of intensive and often toxic treatment. I like this statement very much. However, such intensive therapy can incur substantial academic, developmental and psychosocial costs for children with ALL and considerable financial cost and stress to their families. That's Nelson. 25 years la what is found out by somebody's experience, or 2 lines la it will be there in Nelson. You understand? I remember the 14th edition statement of Nelson, first paragraph says, infants and children cannot advocate for themselves. So pediatricians should be the advocates for them. You understand? You can check whether it's still there or not. It's taken a photograph by the eyes and pasted here. I don't take any photograph for a good slides because I will not see that again. அது எப்போ பார்க்கணுமோ கர்ணனுக்கு மாதிரி அந்த சமயத்தில் மறந்து போகும். அந்த டைமில் அதை ஓப்பன் பண்ணுற அளவுக்கு ஞாபகம் இருந்தால் அது கண்டிப்பாக நமக்கு ஞாபகம் இருக்கும். யூ அண்டர்ஸ்டாண்ட்? ஸோ இந்த ஃபஸ்ட் ஸ்டேட்மெண்ட் ஆஃப் நெல்சன் ஃபஸ்ட் டே படிக்கும்போது வித் ஒரு சுமாரான இங்கிலீஷில் இவ்வளோ ஞாபகம் இருக்குன்னா In the statement la vandu it is written only by experience. You understand? Next. Okay, this is the treatment. So we are not going into the treatment. We are not going to ask the management of leukemia to you, only the concepts of management. Chemotherapy is the management. Next. So for difficult IV access, port insertion has to be done. Next. So CNS directed therapy previously was treated by cranial irradiation, which has been stopped now. So if you say cranial irradiation for leukemia management, it is a wrong thing. Okay, we are treating with intrathecal methotrexate, dexamethasone, and also high dose methotrexate. All will penetrate inside the blood-brain barrier. Next. This is the recent advance for real good MD pediatrics question paper. Okay, there is something called CAR T cells. This is available in US. One of my patient treated in Ramachandra, after the third relapse, is undergoing this treatment in Children's Hospital of Philadelphia, CHOP, and the cost is 4 crores each patient. In China, before the coronavirus, it was 90 lakhs, less than 1 crore. Now it is not possible. In India, Tata Memorial Hospital with IIT Mumbai is trying to bring that for around 70 lakhs. There is one more person also is working on that with very good team in one more institution. I don't want to tell that. That also might come up for 40 lakhs. So the CAR T cells, if it comes to India, it might come from Chennai. You understand? So at least you should be aware that the CAR T cells are something which is really new. Recent advances in pediatrics, or question, immunotherapy can be definitely asked if it is a sensible question paper. So you should know 2 lines about CAR T cell. What is immunotherapy? Natural killer cells. You take any CD positive, CD19 or any T cell, it has to supposed to prevent cancer, but it has failed. So you take out, genetically engineer to boost that multiple times, then inject into the body. It is supposed to destroy the cancer. Okay, the concept is very simple. It is all the technology which is very important. So T cells, which is supposed to fight the cancer, will be made artificially more and then infused inside the body, and it will prevent cancer. It will kill the cancer cells. Apparently in US, the statement made by AAP, American Academy of Pediatrics, is equivalent to ORS. Only because of the cost, it's a problem. How ORS changed the lives of pediatric patients who are dying because of cholera and diarrhea. Now the CAR T cells is going to change. Already it is 90% chance for curable. So it's nothing exaggerated. I am highlighting here just to be aware of that. Next. Okay, so these are the 2 words again in Nelson. Nowadays everything is based on precision medicine, or it is suitable, tailored only for that particular patient. 2 ways. The therapy is determined by your genetic expression. Okay. Second, the therapy is modified by your genetic component. If a child who tolerates 6 mercaptopurine 100 mg, another child is tolerating only 10 mg, it is because of this enzyme thiopurine methyl transferase gene, that is TPMT. Okay, that is a pharmacogenetics. So I don't know why Nelson textbook of pediatric depresses you with all this. Whatever I have learned in the last few years and I am practicing, we do severe neutropenia, not able to increase the dose, we do the TPMT assay. If the TPMT is positive, then we do only 10% of the dose of the normal child. Is it important? Then otherwise they will die of toxicity. Next. Okay, this is the outcome. You can see this. By looking at the outcome, in 1966, only 20% of the patients in US were salvaged. 1966. 1983, now 74% of patients were salvaged. In 2005, 96%. After that, it stopped. Why? They have reached. So when Kalathur Kandamma came, 20%. You understand? You didn't understand. 1962. Now 1983, Varumai Nirav Sivapu came, it was 70%. 2005, Anbe Sivam came, it is 96%. These are landmarks. But where are we? Where are we? That is important. So, it should be depressing as an Indian. Indian too, Indian. Because when 1969, I am sure that diphtheria we were struggling. When CAR T cells are available, we are struggling for flow cytometry and cytogenetics. That is the difference. Next. Okay, so next, I will highlight the important words. Okay, right. Tumor lysis syndrome, we have come across. Superior vena cava mediastinal mass, we have mentioned. Hyperleukocytosis, tumor lysis, we have mentioned. And septic shock. The one thing which is not in this child is paraspinal mass causing paraplegia. Next. Okay, now this is my slides only. I will just explain. So these are 3 cases I am going to show you. Some are old cases only. You can sit there. No, he has not completed. Don't worry. So this is a child who was seen in our OPD and told to have LRI with V's, given salbutamol, azithromycin and prednisolone, had bilateral V's and sent home. When the child came for vaccination, because the child had mild tachypnea, a repeat X-ray showed a effusion. Okay, and there is a mediastinal widening. This is the comparable. If you look at carefully, here itself there is a tracheal shift. So there is a minimal mediastinal widening with a minimal effusion, which was little bit overlooked. But this is very obvious now. When the CT was done, anterior mediastinal mass, when the aspirate from the pleural fluid done was like L3 leukemia, and it was confirmed to have a T cell leukemia. Okay, this is a small child who has grown up now like this, and the child is doing very well in 2009. This is another patient. If this patient comes to you on your night duty day, either you take leave or you cannot sleep. You understand? There's no other option, because this child have a very high chance for death in the night. But the child will not look sick. That is what I am highlighting. Until death, the child will look around normal. But when you are forcing him to do something, the child can collapse. So this child, effusion is there. My point is, if there is a mediastinal mass, don't do any heroic biopsy from the mediastinum. Avoid maximum mediastinum biopsy. If there is a supraclavicular node, you do that. If there is a effusion, you aspirate that. Nothing is there. If the CBC is abnormal, then you do a bone marrow. But not under sedation, after informing ICU, after informing anesthetist who can manage difficult airway. Without that, don't touch the patient. So this child is aspirate, showed T cell NHL again, started on steroid. For 24 hours later, can you believe that? So if you don't take a chest X-ray, if you don't diagnose a leukemia, if you give a steroids for 48 hours, what would have happened? This child will become normal. You will praise the Lord, but actually the child will come back with relapse and will die after that. Again, when you go through the history carefully, that might be not because of your treatment, it is masked by some native medicines or steroids. So beware of anesthetic death in a child with anterior mediastinal mass. This is recently one of my hospital, evening 6:30, child with mediastinal mass went to theatre, had a cardiac arrest and died. So in spite of everything is being prepared. So cardiopulmonary arrest might be our problem also, our arrest also. We need so many things to receive yet. So we cannot, a junior doctor's problem or a duty doctor team can be a problem for the senior most person in that hospital. So mediastinal mass, be very careful. This is last time also I showed you, true case, so I masked this, 1 month back pain. MRI normal. Why? If they go to ortho, back pain, MRI only. Okay. But the CBC showed this. This was my teaching point, 7.5, otherwise well child, 3,500. Platelets 1.2 lakhs, MCV 110. Back pain, disturbing sleep. It is a I have not manipulated anything, it's a true. No differential diagnosis. This is what the combination. Even in US and Australia, considerable time is spent for CBC. But here, we have a doubt now, we depend on the bone marrow and flow cytometry. You understand? So, considerable time. So, this is after that MRI, when you retrospective see, there is a lytic lesion. Last, coming to the next important point, arthritis. That is this child, bone pain or arthritis. Arthritis, differential diagnosis in exam is rheumatic fever, JAA, septic arthritis, hemophilia, trauma, all that. But in a child with arthritis, can we have leukemia or not? Is the question. That is, question was raised in CMC Vellore. This was my chief, and we conducted a study between 10 child with JAA who had arthritis, 10 child with JAA presentation but turned out to be leukemia. Three important points we highlighted. One is presence of night awakening pain. One, already I told you. Second, absolute lymphocytosis versus absolute neutrophilia. So J is neutrophilia, leukemia is lymphocytosis. Third, thrombocytopenia, thrombocytosis. So you don't need anything else. These three things, it is leukemia. But you do bone marrow for everybody because J is a diagnosis of exclusion. So this was told by me in 2000 in a clinical meeting, but this is told by Nelson in the 19th edition. There is no difference. Bone pain is severe and can wake the patient at night and can include joint swelling. You understand? So you are convinced that that can be a differential diagnosis, joint swelling and pain awakening night with pancytopenia with absolute lymphocytosis this is like telling arthritis could be initial presentation of leukemia and 25 years everybody are telling, but I'll show you the next case because this has been told several times, no? At least this is what from early birth a boy will listen to that. Whether this has made any impact I have to do a randomized study. When did we start this? Before that, what was the incident? After this, the incidence is decreased or not. If it is not decreased, probably we should stop this. You know why? Probably this is the cause for reminding everybody. So I have stopped telling now arthritis could be a manifestation of leukemia. This is a recent child, 6-year-old child, multiple joint pain and swelling. You can look at how we can get diverted. Child has got ANA positivity. Bone marrow is normal in a good hospital by one of the best doctor and treated with native medicines, but came to our rheumatologist and finally, when we examined, there is the same findings like what he told us. And this is completely misleading. Hemoglobin is 9.7, no predominant lymphocytes, platelets is thrombocytosis. True case. But we had only the same smoking kills. Arthritis, presentation of ALL. So we repeated the bone marrow. Before that, we did a good thing is we took X-ray lytic lesions and we analyzed and everything. Finally, we went again with the bone marrow. It was full of blast. So all these Siddha medicines, ANA positivity, all these can confuse you. But still, if you remember very, very non-intelligent night awakening pain with arthritis, do a bone marrow. And if there is a doubt about given Siddha medicines, do flow cytometry directly. So this is BALL. Now last or important point concept I want to highlight is, we are talking about bone marrow transplant one side, CAR T cells one side, but when there is a relapse, most of our patients will die. So let me introduce an old concept called palliation. If you talk to the patient well about death, prepare them about death, and ask them their wishes. There is a child who was 10 years old, ALL, very early relapse, T cell, decided to have palliation. She had 3 wishes. One is the treating doctors and the nurses should attend a dinner with her in Besant Nagar. They enjoyed. Then she wanted to meet Dhanush. We have a very close contact. He came. She wanted to watch a movie with me, so we watched with my daughter sitting next. And then subsequently she died. And that was the 3 important moments the parents appreciated. After the death, the 24 hours later, they came and thanked. That is the impact. Okay. Now this is another one sad story is, can you make out the diagnosis for this child? Down syndrome, ALL. Once recently we went, this father died of a road traffic accident and the mother donated his organs. 2 months later, this child relapsed and the child died. One point I want to highlight is, this child was in ICU, struggling for intubation, not able to be sedated. You know, when I went there, I easily settled. How? No ventilation, only mother's lap, child remained calm, mother remained calm, and the child died. And the mother came yesterday. That is the maximum award I can remember in my lifetime. Yesterday came to distribute fruits on her birthday, and she thanked for the moment when I went inside. So there is no heroic measures needed when there is nothing much can be done. That statement I don't like. Nothing much can be done medically. But socially, many things can be done. Many things can be done. You understand? So the previous concept of palliation, I have been highlighting to many celebrities, whether we can have a good palliative intent hospital, not only for oncology, for many. You understand? This is considered as a very important seat. Many people in Tamil Nadu will be wanting to sit there, isn't it? but I am from the opposite party, he knows, so there is no confusion in that. But my final message is, when there is a person who takes up a specialty with a good institution beyond exam, not only by technology and by the recent advances, by the concept of palliation, with a good fundraising, with awareness through celebrities, and with involvement with many NGOs, and with the government support, we can really do very good things. So there is a life beyond exam. I'm sure you will do very well. That is why I don't fail anybody, because the exam starts after the exam day only, every day. You understand? Thank you. And I appreciate Siddharth. I appreciate Siddharth for very prompt. Only 2 days we had some time for discussion. Whenever I called, he responded well. So I want to give a gift for him. Sir, can you please give? This is something I like. Okay. Because there is 2 minutes time, I just want him to read one line from this. Take page 50. This is Dr. APJ Abdul Kalam's book on my journey. I have read several times. He will read that statement now.
This simple lady, born and raised in a small southern Indian town, was perhaps like many other mothers in our land and beyond. She did not step out of the house and take part in the affairs of the town. She did not make a career in the way we think of it nowadays. Her realm of work remained the home and the family. Yet within that she served everyone and God with utmost devotion, selflessness and pity. It is this lesson that I have carried from her life, that it does not matter how large or small your sphere of activity is. What counts finally is the commitment that you bring to the job that has been ordained for you in this life.
Abdul Kalam's mother, he has written. I am sure that Abdul Kalam's mother would not have stood in the stage and got a standing ovation or anything. So, on a Women's Day, this is all is enough. I don't celebrate Women's Day or give any wife. No, I don't give any gift on that day, because if you appreciate, if I write the book, one paragraph I will write about my mother. Obviously about wife also. You are recording, no? Okay. So thank you, sir. Thank you.